ideal regimens. So whatever we use is not ideal, but it still works. So if we look at atropine, it's regarded as the gold standard cycloplegic agent for pediatric refractions. But it has a problem because it has most of the severe side effects, and it also has a very long duration of action. And it's not recommended for routine cycloplegic refraction in school-age children or adults due to this prolonged paralysis of accommodation affecting near vision. It's one of the most potent cycloplegic agents, and usually young children, we ought to use 0.5%, which I don't think we have locally in our market, and 1% in the older age group. The administration, we use 1 drop twice a day for 2 days. Although there are studies done which shows even if it's used once a day, it can give cycloplegia. But remember, we deal with the patients who have.
What is the point of this CRC?
Who have dark irides. So you find our patient probably administration of atropine once a day might not be effective. It has a slow onset of action beginning in 20 minutes and reaches peak in 3 hours. So very unlikely to be used in the clinic setting unless the patient puts it at home, then comes back to the clinic. And the duration of action lasts up to 2 weeks, but the accommodation effect is abolished earlier. So probably 2 or 3 days earlier than the mediatic effect. So there are various side effects, ocular and systemic. In the ocular, we have allergic contact dermatitis of the lids. They can have associated allergic conjunctivitis. Some may get keratitis. And we know all cycloplegics and mediatics would cause an increase in IOP. So the systemic side effects that we often encounter is dryness of the secretions, that they present with the dry mouth. They may have fever. Actually, fever is one of the systemic effects that we encounter. Diffuse cutaneous flush. They may have increase in heart rate, urinary retention, restlessness, irritability, incoherent speech. That's when now they have the toxicity, severe toxicity, ataxia, confusion, and it may even lead to death. So even though we use it as a cycloplegic drug, it can be used for other purposes. And when we use it for other purposes in children, we should be very cautious to know probably how we should administer it because of the side effects that it has. So it can be used in the treatment of myopia, but it's used as myopin, which is 0.01%, which in literature, I didn't find that it would give us enough cycloplegia for refraction. So myopin would only be used for in myopic patients to stop the progression of myopia. Treatment of mild and moderate amblyopia, what we call penalization. It can be used in pain relief from serious spasms, treatment of uveitis. And also we should be very cautious in patients with Down syndrome and albinos and children with heart conditions, because remember it increases the heart rate. And in literature, it has been reported, there are 6 cases reported to death to have occurred in 6 patients who are less than 3 years of age after the use of atropine. So the second one is cyclopentolate eye drops, which was introduced into the clinical practice in 1951. and is considered the drug of choice for routine use nearly in all age groups. And infants, we are supposed to use 0.5%. It has a fast onset of action and shorter duration of effect. Is equally effective as atropine in case of older children when we are doing cyclorefraction in older children. The cycloplegia occurs within 30 to 45 minutes of instillation, but is stable up to 90 minutes. So we can conduct a refraction between 1 hour and that 90 minutes. The cycloplegic effect washes out in 6 to 8 hours. That's why you cannot send a patient home with the cyclopentolate to go instill it at home for 1 or 2 days, the way we do with atropine, because it will not work. By the time they come back, the cycloplegic effect has already washed out. But full recovery of mydriasis occurs within 24 hours. And having mydriasis does not really mean that there is cycloplegia. So it still has some ocular and systemic side effects like atropine, but some of them are to a lesser degree. So there is irritation and diffuse redness of the eyes. And actually you notice this when the patient is in the clinic. There is facial rash that develops within minutes to hours of instillation. And parents tend to inform you when you are calling them back for refraction, they may start telling you they are seeing a rash around the face or around the iris. There's lacrimation, and there is whitish mucus discharge. And they tell you when they came to the clinic, there was no discharge, but now the child is having a bit of white discharge. Then, of course, because of the dilatation, there's blood effusion. Systemic side effects, drowsiness, ataxia, disorientation, disturbance in speech, restlessness, facial hallucination, which is more common than with atropine, and it tends to induce confusions and psychotic behavior in children more than when we use atropine. So we have TROPICAMIDE eye drops, which is a synthetic analog of tropic acid, and we have it at 0.5 and 1% solutions. So it's the 1% solution that has a cycloplegic effect. So if in the clinic you have the 0.5%, you cannot use it to perform cycloplegic refraction. The onset of action is about 15 to 30 minutes and lasts about 4 to 6 hours. So we can conduct our refraction within that 30 to 40 minutes. And the pupillary dilatation with TROPICAMIDE is less dependent on iris pigmentation, unlike atropine and cyclopentolate. So this one, it doesn't matter whether you have the dark iris or the brown one. The ocular side effects are stinging, sensation in the eye, corneal irritation, and the increase in IOP, like every other mydriatic and cycloplegic drop. Systemic side effects is dry mucous membranes, flushing, and tachycardia. So you realize the cyclopentolate and the atropine will have more CNS effects because they cross the blood-brain barrier, unlike the TROPICAMIDE. So we have the HOMATROPINE, and I came across HOMATROPINE, I think, when I joined the MENT, the first 1 or 2 years. We used to have it in the department, and it's 1/10 as potent as atropine. It has a shorter duration of mydriasis and cycloplegia, and we administer 1 drop, repeated 5 to 10 minutes interval. We can give 2 doses, and has a duration of action of 1 to 3 days with an onset of approximately 30 to 60 minutes. So the refraction is conducted after 1 hour. There's prolonged mydriatic and cycloplegic action than cyclopentolate and TROPICAMIDE. So it becomes less favorable than cyclopentolate and tropicamide. And it gives eye swelling, redness, or crusting, puffy eyelids, agitation, but less than atropine and cyclopentolate. So how do we make a choice of cycloplegic agent? The choice of this drug will depend on the strength, whether you need a 0.5 or 1% or 2%, depending on how the drug is formulated. Then the duration of action, because if you give atropine, you know, patients have to go home and come back. Duration of the effect, the age of the patient, because you're not going to give atropine 1% to a 1-year-old twice a day or 3 times a day for 2 days. They will come back with the toxicity. The presence of strabismus and poor vision, because if there is anisotropia, then most likely we will be needing atropine or we will be needing cyclopentolate. And also depending on the anticipated side effects and the existing medical conditions, because we have seen we tend to avoid cyclopentolate in patients who have convulsive disorders and mental issues. We give them with caution, and for the ones with heart disease and patients with Down syndrome, we tend to give atropine with caution. So that one will help us in choosing the cycloplegic agent that we need. So that is a table showing the onset and recovery. The topmost, you can see the 4 types of drugs that we would use as cycloplegics, which are also mediatics, and their strengths. And atropine tends to be used in children who are younger, because remember, 1, they are not going to school, and 2, they have a lot of high accommodation, especially when they have a strabismus, convergent strabismus. So if you look at the mydriasis and the paralysis of accommodation, you can find the that the actually mydriasis will occur earlier than paralysis of accommodation, or more than the cycloplegia. So for atropine, you find that people can be dilated within 30 to 40 minutes, but the paralysis of accommodation will come within 1 to 3 hours. So as I had said, dilatation does really not mean that there will be cycloplegia. So all of them, you can see there is a variance, except for HOMATROPINE and even cyclopentolate, although with cyclopentolate at times you put it, and within 45 minutes you find still the pupils are not dilated. But if you give the patient some time, probably to go to 1 hour, you find it will be mid-dilated. And within that 1 hour, we know that we have cycloplegia. So, and this is probably what I mean in terms of mydriasis and cycloplegia. They do not complete at the same time. And especially for cyclopentolate, the cycloplegia is completed prior to mydriasis. So often, when there is complete mydriasis, the cycloplegia is considered to be complete for the refraction. But if the mydriasis has not occurred, but probably we had put cyclopentolate 2 drops, 10 minutes apart, and it's 1 hour, and the pupil is mid-dilated, then we can still go ahead and refract the patient. The only issue we'll have is we can't do probably a full FADAS examination with a mid-dilated pupil. So if pupillary dilatation is used to determine whether cycloplegia is at the level of refraction, the refraction may be delayed or additional drug may be used unnecessarily. And that's what we should inform our patient attendants or assistants or the nurses who assist us if we need them to instill for us a cycloplegic drug so that they don't keep on adding. So when you're seeing other patients, they come check probably after 30 minutes or 45 minutes, then they find it's not dilated, the tendency is to add. But we should advise them that we only need 2 drops to be put, and we give the patient time to wait for the dilatation and also the cycloplegia. So what are the indications or the need for cycloplegia? Because definitely, even if the drugs have side effects, we still needed to do cycloplegia. So one, we needed to gain a few of the funders, especially in children who are difficult to examine. Any young child suspected to have significant hyperopia or astigmatism, young children with suspected poor vision in one eye or both eyes, suspected strabismus or large folias, any case of suspected amblyopia, and any case of suspected malingering. Children with a strong family history of childhood visual problems, children or adults with learning or communication difficulties, because this is the only way probably if they need a refractive correction or if they need any further examination that you'll be able to perform them. Older children experiencing headaches, unexplained reduced vision. We have also people who have pseudomyopia, that you have a refractive problem that keep on changing and not stable, so they need cycloplegic refraction. So that's a summary of all the side effects of the various drugs that we have: atropine, cyclopentolate, HOMATROPINE, and TROPICAMIDE. So you can see the atropine and the cyclopentolate, they tend to have CNS problems more. Unlike the TROPICAMIDE, HOMATROPINE will be borderline. But the first top ones, which are the ones in our market, we don't actually have HOMATROPINE in the market, are the ones which are associated more with the CNS problem because of their crossing the blood-brain barrier. I want to give a short a case that I encountered, and I think there were 2 or 3 patients in 2019. And I had a 6.5-year-old girl who I had seen previously with mixed astigmatism. And this time they came for follow-up and to upgrade the spectacles. She had no remarkable present or past medical history. And the eye examination that day was 6.24 without correction and 6 of a 9.5 with correction. She was orthophoric, and the ocular motility was free. Anterior segment was normal with IOPs of 14 and 13. So we plan to do cyclorefraction by using the 1% cyclopentolate eye drop. She was 6.5, but previously I had done it with atropine. So we give 1 drop, both eyes, and 2 drops, 1 drop repeated after 10 minutes. So we instilled 2 drops in each eye, and was supposed to be examined within 45 to 60 minutes. Well, it's not I who instilled the medication, it's our patient attendants. So I couldn't tell whether there was medicine that poured on the cheeks or not. So after 45 minutes, the father reported to the patient attendant that the child has altered behavior. Actually, after they visited the bedroom, then she came in the washroom. He came and reported altered behavior, where the child had visual hallucinations, difficulties in walking, disorientation with ataxic gait, and slurred speech. However, the pupils were dilated. She had no fever, and the rest of the examination was unremarkable. And I think that's the first time I saw cyclopentolate systemic toxicity. That is the diagnosis we made. So we put the child to lie on the couch. We gave her some water and we waited for a few hours before she could stabilize. And when I called the father the following day after they left the clinic, she was stable. I actually didn't know whether to refer to the hospital or what to do that day. The second patient was atropine toxicity. February last year, a 9-year-old girl who had intermittent exotropia for 7 years had been referred for cycloplegic refraction. She had been prescribed for atropine eye drops twice a day for 3 days, 1 week before. So she was coming for refraction. She was coming to me for refraction, having been referred by a colleague. Her vision was 6.9. Her vision prior to cycloplegia was 6.9, and there was documented exotropia with no remarkable past medical history, and the anterior segment was normal from the previous notes. When they arrived in the hospital, she was brought handicapped by the mother and one of the older sisters. She had a temperature of 39.5, a heart rate of 104, and a respiratory rate of 28. She had blurred vision, altered mental status, anxious, confused, restless, and incoherent. And on inquiry, the mother told me they had administered the whole bottle of atropine within 5 days. So definitely we knew that it was atropine toxicity. And the nurses in OPD started her on supportive measures in the specialist clinic. Then she was referred to OPD to monitor the heart rate, the oxygen saturation, and probably even to do the ECG, because they tended to have, because of the tachycardia, they tend to have arrhythmias. And then because of also the change in mental status, some may need also an antidote of physiostigmine. So she was referred to OPD, but they managed to sort her out without the antidote. And after 3 hours, she was released. So how can cycloplegic toxicity be avoided or minimized? So we know that the toxicity, systemic toxicity, is dose related. So the more drops you use, the higher the percentage, then we expect to have toxicity. So we need a good medical and ocular history from the patient that we are dealing with. So also we see the kind of cycloplegic we would use, the age of the patient, so that we also know what percentage to use, the appropriate cycloplegia, and the percentage for different age groups, the dosage, because we are supposed to give the minimum number of drops that gives us cycloplegia, then proper indication for cycloplegia. Because like this girl who had intermittent exotropia, I really don't think she warranted atropine. Her refraction could comfortably be done with cyclopentolate. Her vision was good, 6/9. So even if she had an error, was just a minimal error, and probably even TROPICAMIDE 1% would have sorted out. Then we occlude the nasolacrimal sac during instillation. So if it's the mother instilling, or even if it's the doctor or the nurse, we advise the mother to occlude the nasolacrimal sac so that we avoid systemic absorption. Then proper counseling of parents, assistance on how to administer the drug, and also the parents should understand what cycloplegia do. If it's atropine, we tell them not to exceed the dosage. And if they exceed or if they don't put in an appropriate way, then the children might end up having this toxicity. So when they are explained to, they are very cautious when they are administering the cycloplegics. So several bodies and researchers have some common findings, like the American Academy of Ophthalmologists, the American Optician Association, and some of the findings they have come up with are a cyclopentolate to be used as a drug of choice as a cycloplegic unless it is contraindicated. And 2 drops separated by 5 or 10 minutes apart, if combined with tropicamide 1%, it would give better results, and especially when it comes to dilatation. So the cyclopentolate would give cycloplegia, then there will be an added advantage because of the tropicamide 1%, and we end up with dilatation at the end of the day, and we will be able to do fundoscopy. Atropine eye drops are indicated in accommodative and hyperopic young children, and also in pseudomyopia. Tropicamide 1% is found to offer cycloplegic effect in no refractive errors. So if we have a patient who, after we swing our retinoscope and we find that the reflex is very down and we suspect we have a very high error, it's very unlikely we will prescribe tropicamide as a cycloplegic. Then great care is required when administering cycloplegics so that we avoid most of the side effects. So I add by putting that table there, because after we have done our cycloplegic refraction, then for those who need spectacles, we should know when to prescribe and when not to prescribe. So between 1 to 2 years, 2 to 4, 4 to 6, when they need spectacles, because there are some situations where you find you refract a child, like that girl who had intermittent exotropia. You find she's a plus 1.25. It will really not correct her exotropia. It will even probably make it worse if you prescribed. So there is a need to know the indications of when to prescribe the spectacles. So thank you for listening to me, and that's where I end my talk.
Thank you, Dr. Njuguna, for that detailed and informative presentation, and very interesting too. So at this point, I'll go to the Q&A, and if you have any question, you can type, or you can also raise your hand, and we'll tackle them. So I'll start with the first question. So the first one is asking, would you advocate for instilling topical anesthetic drops before putting cyclopentolate? Because cyclopentolate stings when instilled.
There are some, actually I came some papers which were saying we would use local anesthetic, and I think there were 1 or 2 local anesthetic. It's not every local anesthetic that we would use. And there was a randomized controlled study. I can't tell whether it was in Pakistan. And because they were saying there are only 2 doses, they didn't see the need of putting a local anesthetic in case, I don't know, when the child rubs the eye and there is no anesthesia, they might traumatize the cornea. So that was one of the criteria that they used. But well, if we have the light local anesthetic, we can instill. But remember, we will only put 1, so we will be using 3 drops. yeah, 3 drops. We put the local anesthetic, then after 1 or 2 minutes, we put the cyclopentorate. So there are some who have advocated, there are some who didn't advocate. And I've put without local anesthetic, and I have seen it work. So, and I tell them it stings, especially the ones above 4 years, because they understand. I tell them it will sting a bit.
Okay, thank you. The next question is availability of atropine in ointment form is always an issue. Do you have any specific brand which is available most of the time?
For the ointment?
Yes.
I've never seen ATROPINE ointment myself. I don't know.
Yes, I don't think it's available in Kenya.
Mm.
And also there's also a challenge on the availability of the 0.5% atropine and cyclopentolate. Many times you'll find the 1%. Okay, the next
and because and because the 0.5% of atropine and cyclopentolate is advocated for infants. Probably we could use TROPICAMIDE 1%, and within 4-6 months, they're above 1 year. Because I don't think we will be refracting a neonate or a 2-month-old baby. I don't know how, if you are doing cycloplegic refraction, how they are going to wear glasses, even if you found +10 at 2 months.
Okay. The next question is, at what point do we give the tropicamide when combining it with cyclopentolate?
There's one study where they put it 2 minutes. They combined cyclopentolate with the tropicamide. So you put cyclopentolate. After 2.5 minutes, you put the tropicamide. Then at 10 minutes, you put the cyclopentolate. And after 2.5 minutes, you put the tropicamide. So it's like you are having 4 drops. Then other studies advocate, you put your cyclopentolate at 0 minutes, then you put your second dose between 5 to 10 minutes. Then probably by the end of 30 minutes, you can drop the tropicamide. Because remember, it will take about 30 minutes to work, and you want to refract your patient within 1 hour. So before 30 minutes, you can put your tropicamide, 1%.
Would you also comment about using 3 drops? Because traditionally we have used 3 drops of cyclopentolate at you start at 5 minutes interval, so that by 15 minutes, by 10 minutes, you put the 3 drops.
Actually, most of the recent studies have shown using 2 drops. Remember, I said we use the minimum number of drops that it gives you cycloplegia.
Yeah.
Yes, so that's why they were advocating the 2 drops. And because, with the 2 drops, you might not have a maximum mydriasis. That's why you are adding a tropicamide, and 1% because also it has additional cycloplegia. And it's more safer than giving an overdose of cyclopentolate.
Okay, I think that's something very interesting. Maybe someone else can also give their observation, because sometimes I feel like when you use, actually even when you use cyclopentolate, sometimes the children still accommodate. I probably is that they don't put the drops as it's supposed to, or I don't know whether it's an issue of the African eye and the dark iris. So it would also be a very interesting observation to investigate or even research around and see whether our patients, the African patients, still respond well to 2 drops or 3 drops or even a combination. The next question
sorry?
is...
Sorry, like one of the studies, actually, they did it in Ghana.
Okay.
I think Cape Coast. And remember, these patients, we are not giving it in a patient we expect they have accommodative spasms or they have anisotropia, which has hyperopia and isotropia. So that one probably would reserve for atropine. But any other, these school-going children who are walking to the clinic, they are 7, they are 10 years, we have taken their vision, we have taken the history, and we don't suspect an accommodative squint, or we don't see anisotropia, then we can comfortably refract them in the clinic with the cyclopentolate. And I don't know what, I don't know whether Zara is in session. She does quite a number of refractions. But sorry whether she's in.
I had seen her, she can comment. I totally agree. For the routine refraction cyclopentolate, and maybe probably in the older children.
Yes.
Yes, not the very young, because the toxicity is more in the younger ones. The next question is, in management of progressive myopia, what is the recommended dosage, considering the recent side effects?
Progressive myopia.
Yes.
As a form of treatment, to treat with the atropine or to do refraction, because myopine is the one which is used to slow down the myopia, which is 0.01%. And even there are papers which, there were some comments in some papers that they were showing 0.5% was working better than the 0.01%. But then the patients would withdraw within a few months because of the problems they will face of mydriasis and cycloplegia. When they go to school, they are not able to read. And that's why I think the myopine or the myopia group came with the raw dosages that patients can tolerate. And I don't know whether Zara had covered something on myopine sometimes back. I think she had presented something on using myopine.
Yes, she did.
Yes, she did, yeah. So, but in my opinion, sorry, I've even seen patients coming to the clinic with a bottle of myopine for cycloplegic refraction, given as a cycloplegia, so that they will come for refraction. So it will not work. It's 0.01. But for progression of myopia, because they use it daily, that one will work at 0.1%.
Okay, thank you. Thank you for excellent presentation. The next question is, how do you correct for accommodation when prescribing glasses? I guess using the different agents, atropine, cyclopentolate, and TROPICAMIDE, if you have to use it.
How the toners of accommodation?
Yes, that's what I believe. That's what the question is about, the toners of accommodation.
Okay, so if I have used atropine and I find +4, that's what the person is asking. So whether we will go down with 1 or 1.5 diopters.
Yes.
If we have used atropine,
yes.
cyclopentolate, they talk about 0.75 to 1%. So long as the patient doesn't have accommodative isotropia. If they have accommodative isotropia, then they will get a full correction of the cycloplegic refraction. So
that
it's 1 to 1.5 for atropine, 0.75 to 1 for cyclopentolate.
I hope that is clear, that the only time you do not change anything is if you have accommodative isotropia. Okay, I can go to the next question. Maybe I could also comment, Dr. Njuguna, that for TROPICAMIDE, they don't recommend that you change anything.
Yes.
Yeah, you just give us what you have found. The next question is, given that atropine cycloplegia is maximum within 1 to 3 hours, would you recommend having the atropine administered in clinics as opposed to sending the patients home?
So it shows that it goes to maximum, but is maintained up to 80 days. And it is best at its day 2. They'll tell you the peak might be 3 hours, but it's best at day 2. And we have tried in the clinic, you give atropine in 2 hours, they are still not dilated. And you see, it means that you are giving 1 drop of atropine, which will not give you maximal cycloplegia in those 3 hours for an accommodative vessel. So that's why, although it's documented that in 3 hours that you'll have a cycloplegia, I don't think it would be effective for the kind of patient you want to reflect. The one with the high hyperopia, with accommodative vessel, within those 3 hours, it will not work. But if we had the patient we are talking about, the low myopias without high LS, then it would work. But remember, even after you instill that drop, you still have a week of loss of accommodation and mydriasis. And then it is for young children. You remember we said usually the ones below 5 or below 6, majority of them use atropine. So they're the ones who will be putting it home.
Would you also comment, Dr. about the combining cyclopentolate and atropine in the clinic? The indications and who you put such drops and who you can't do that?
Where there is contraindication of cyclopentolate, we will not put cyclopentolate. If the patient also had a contraindication for atropine, we will not. But we have patients who you find they are 10 years old, they are accommodating, we can put a drop of atropine, and then we follow with a drop of cyclopentolate. 1 or 2. And it's a method, I had read in one of the German papers where they were saying actually you could combine. But you realize when you combine them, your patients tend to have more toxicity because you'll be using like 4 drops in one sitting. If you check those children, you'll find they're having a bit of more toxicity than the ones who put atropine at home for those 2-3 days, and the ones who use 2 doses of cyclopentolate. So you'd probably use it on the older children, but remember, even if they are 8 or 10 years, we still have another week of atropine acting in the eye. So most of the times you'll find they discourage, although they used to advocate for it, most of the times they discourage it so that you use the minimum number of drops that you give us cycloplegia with the less side effects.
Thank you. There is also the practice of putting atropine for the younger children for the less than 2 years, where you give the atropine once a day rather than twice a day to minimize the toxicity. But in that case, then you'd have to give it 3 to 4 days.
3 to 4 days, yes.
Yeah, in the morning, once a day, yeah, to minimize the toxicity.
And also the other thing I realized we really don't explain to the mothers, they occlude the nasolacrimal sac. That's one thing we hardly tell them. Despite telling them the side effects of these drugs, we hardly tell them to occlude the nasolacrimal sac to avoid the systemic absorption. So I think it's one of the things as we explain the side effects that we should be reminding them to do, and we demonstrate how they should do it.
Yes, and also wiping the face drug that spills over. Sometimes they put so many drops that fall on the skin before the right drop gets into the eye.
Yeah.
Yeah. Thank you, Dr. Njuguna. So this is a comment from Dr. Beth. He had 2 young children around 8 years of age that developed systemic side effects, cyclopentolate. It is quite scary, but ended well. Yeah, it's quite scary, I must admit. I also had an experience where I got about a 5-year-old boy who got similar side effects. Incoherent, ataxia, he was collapsing, and everybody was very scared, but it ended well. But unfortunately, they have never come back to the clinic. So I think they associated it with the treatment they were given. So it can be quite scary, yeah.
And I think it's the same time when I got the patient. And what has been going through my mind, I was suspecting that cyclopentolate blood could have been 2%, not 1%.
Yes, it's
probably
possible.
from the factory is labeled 1%, but it could have been 2% because it's the one that gave us problems.
Mm-hmm. Yeah, it's possible because I've also never seen, I've always read about these side effects. So even recognizing them at first, it was a bit difficult, but we could not associate it to anything else. And it was so sudden after installation of the drops. Comment about the atropine ointment. I hope the people supplying the drugs are noting. It will be very useful because it would reduce the systemic absorption, and also having the lower doses of atropine and cyclopentolate. Great presentation, very many comments about that. There's another question. Would 0.5 atropine, okay, atropine, it's a comment and a question. Atropine 0.5 is available at Kikuyu Hospital. Would atropine 0.5 as OD dose give effective cycloplegia in infants?
I don't know, unless probably use it for those 3-4 days, the way we do with the 1%. Because the tendency is to give it 0.5 twice a day. A total of about 4 doses, but we don't give the day of the cycloplegia.
Okay, thank you.
The cyclorefraction, sorry. We don't give it the day we are doing the cyclorefraction.
Yeah, I read somewhere that you need a minimum of 4 doses. Is it 4 doses? Yes. So that if you are doing BD, you do 2 days. If you are doing OD, you do 4 days.
4 days, yes.
Yeah, so that you have at least 4 doses of the cycloplegic drug for it to be effective, the atropine, that is. Dr. Mundia, I find using proximetacaine helpful before cyclopentolate. The child is also more friendly during refraction. I guess that is about the topical anesthetic drop.
Yeah.
Then the drop should not sting, because if you're putting a drop that is stinging before another one that is stinging, the child will already be very agitated. Yeah, so maybe Dr. Mundia can tell us where he gets that nice drop that we can adopt to into our practice. A question about the progressive myopia again. How long does one use a myopin for progressive myopia? I don't know whether I leave this to you or to
Zara.
Zara.
Zara has patients who are neat.
Zara, if you're still there.
I think she's out.
Yeah, as we wait for her comments, we can go to the next one. I know she had indicated the time you use. I can't remember very well. I think about a year or so, then you review and see whether there's progression or not. But I would leave that to her to comment. Many thanks for a great presentation. Thank you, Dr. Njuguna. Could you comment on variations in side effects with the generics?
With generics of atropine?
Yeah, I guess the generic products that are now more available in the market.
Now, whatever we had, what was giving us problem, we can't tell whether it was a generic. I think it was a generic. We can't say the name, but
yes. Or it could be that batch that had a problem. Sometimes it happens that you have a specific batch that has a problem. So it would be a bit difficult to comment on that at this forum. Would need to do more investigation.
Or what I suspect is that it was of a higher concentration, although labeled it was 1%.
1%.
Yes.
Yeah. Okay. A great suggestion from Dr. Gishangi. Is it possible we could do a flow chart on this as a protocol for cycloplegic refraction? I think this is a great suggestion and could be one of the practice, SOPs on cycloplegic refraction. Well taken, Dr. Gishangi. 2 patients. Yeah, somebody is commenting about the batch. I think it was a certain batch that had an issue. Excellent presentation and discussion. Thanks for highlighting the main differences between the various drops. Asante sana. I think that is the end of all the questions that have been typed. Unless someone else has another question that they would want to ask, or if Zara is available to comment about the myopin. I don't think there's any other comment. Maybe Dr. Njuguna, about routine use of TROPICAMIDE. What would you say? 1%? Is it? Could you routinely use it for refraction and confidently prescribe based on that in African eye?
Probably in very low refractive errors. But hyperopias, I had read out. But a myop, I think you can do the raw myopias, which I think by the time you have a child who is 10 years, if they fixate a distance and you are very good to keep them attentive, you'll be able to do a good dry retinoscopy and do a subjective. But you can use TROPICAMIDE, but not in very high errors, because you still accommodate.
Yeah, what I also tend to do is, even if I use TROPICAMIDE or some CYCLOPENTOLATE and I have a feeling they're still, I can see they're still accommodating, I fog the eye, and so that you reduce the accommodation. Now you try and do the retinoscopy. Okay, I don't see any other questions or comments. So I'll take you back to Dr. Kalu for the rest of the evening program. Thank you very much, Dr. Njuguna. That was a very enlightening presentation, very informative, and had a great discussion and a good revision. I can see Dr. Mukaya saying it reminds her of the pediatric Wednesday clinic. So I hope you'll be more confident to do more refractions and prescribe. Thank you very much.
Thank you.
Thank you very much, Dr. Njuguna. That was a very wonderful presentation, and we have cleared quite a number of things maybe we didn't understand before. I beg your indulgence, kidogo, for our today's sponsor. It's a new sponsor for us on our forum, Dawa Pharmaceuticals. We allow them introduce themselves and inform us about their products before we can close for the day. Evans, karibu.
Thank you very much, Dr. Kalu, and good evening, everyone. Thank you for joining this session. I'll take you through a brief overview of Dawa and then share with you our product offering in the eye care space. I'll be sharing my slides shortly. So my name is Ivan Sambagara, and I'm a product manager with Dawa Limited. Sorry, Dr. Kalu, can you confirm if my screen is visible?
You are not yet sharing.
Okay.
We still not, okay. Yes.
You can see it now, yeah?
You can see it, yes.
Okay. All right, as I mentioned, my name is Ivan Sambagara. I'm a product manager at Dawa Limited, and I'll take you through a session, tell you more about Dawa Group and our product offerings within the eye space. Okay, the slides are not moving. Okay, yeah, I think now it's okay. So this is just an image of our corporate offices at Ruaraka. And in brief, Dawa Group is a leading pharmaceutical manufacturer in East Africa, and our commitment is to deliver the best value to patients through partnership with scientific community and investing in quality and medical education. And that's the basis for us participating in such forums. And as Dr. Kalu has said that we've not been participating. And I would like to say that this is the beginning of more interactions with the associations and participating in more of the events. So who's Dawa Group? Dawa Group is made up of two divisions. We have the Dawa Limited, which is our manufacturing arm. And we manufacture and distribute pharmaceutical products. The other arm is the Medicel Kenya Limited. And this is the arm that is involved with the importation, distribution, marketing of pharmaceutical products. So the idea is, on top of the products that we manufacture locally, we go ahead to also source for more products that we feel are strategic and required by the market to be able to take care of the pharmaceutical needs of the different specialties. Our promise to the healthcare providers and the medical field is that we offer quality and effective medication and also provide this through an effective supply and distribution channel. And just to emphasize that our manufacturing is up to the WHO standards, and we are an ISO certified manufacturing plant. So on the eye care, Dawa Eye Care Solutions, we have two divisions again. So we've divided it in the eye drops division. Under this, we have the OROLAB products, and this is affiliated to the Aravind Eye Care System. So what we point out is that actually the eye products that are provided are manufactured with the patients in mind. So OROLAB is the manufacturing arm of the Aravind Eye Care System. And so the patient is put in mind from the very beginning. And then for the ophthalmic devices division, we have Cedar Farm. These are European company for all your ophthalmic and medical disposable products. So some of the products that we offer include the ophthalmic knives, intraocular lenses, and ophthalmic drapes. So for the devices, we'll organize for another forum we'll discuss, but today the focus will be on the eye drops division. So with this, we said that actually for you, Dawa is a one-stop shop for all your ophthalmic devices and products need in terms of the eye drops as well. For the OROLAB range, we want to emphasize that we have products that caters for the entire majority of the conditions that you will have to manage when managing your patients. And today, specifically, something that is very related and appropriate for the subject of discussion, we have two products, which are the diagnostics. We categorize them as the diagnostics. And after this, we have Atrop. That's our brand of the ATROPINE, which Daktari has spent a lot of time and spoken about, and as well as AUROMIDE Plus. So the atropine sulfate, that's the brand of, the brand is Atrop, and it's 1%. Daktari has said a lot. I won't belabor much on this point. So I'll also mention the other product, that's AUROMIDE Plus, TROPICAMIDE as well, but this is 0.8%. Daktari has also spent a lot of time and discussed about the two cycloplegics. And he said that AUROMIDE Plus has additionally phenylephrine 5%. So the idea is actually to make it more effective in the dilation of the patients when heading for examination. So we say that for all your cycloplegic needs, AUROLAB has the solutions through the Dawa Group. Other products that we have within our portfolio include the NSAIDs, that's Ketorolac, that is Ketorolac. We have an anti-allergic, that's the sodium chromoglycate, Orochrome. We have anti-infectives and corticosteroid combination. We have Topdex, that's combining tobramycin and dexamethasone. And also, until the end of last year and beginning of this year, we had Aurocol DM, which our manufacturer brought to our attention that it has stability issues, which they're still investigating. And Dawa Group, being a responsible organization, we decided to put a stop on the promotion and distribution of the product and had a product recall until the issue is resolved. So the manufacturer mentioned that stability issues after 12 months is not guaranteed, and that's something they are working on to come up with a permanent solution. But in the meantime, we feel that we still have a product offering to cover for that space, and that's Topdex, tobramycin, and dexamethasone, which will cover the better part of the discussion this evening. Other products that we have, anti-infectives, we have moxifloxacin, called Mflox, or floxacin, Oroflox. And for the glaucoma, we have Oroprost, that's latanoprost. And also to highlight that Auroprost is a RT, we say, that can be kept at room temperature, doesn't require refrigeration, making it convenient and easy to use across the different geographical areas within the country. Additional product for anti-glaucoma is the Orotin, that's Timolol. And then we also have pilocarpine nitrate, that's Pilo. For eye lubricants, we have Aurosol, that's Hypromelos, and antifungals, we have Econazole. The brand name is Aurozol, and voriconazole, the brand is Vozol. Astringent, we have Zinco, and corticosteroid, we have Oropred, that's Brenisolone sodium phosphate. So Topdex, we say it's a combination of tobramycin and dexamethasone, 0.3% and 0.1% respectively, offering dual benefit in infected inflammatory eye. We say that we know the benefits that dexamethasone possesses. It has a high degree of anti-inflammatory activities and considered one of the high efficacy steroids, and tobramycin is a broad-spectrum antibiotic and is FDA approved for the management of superficial ocular infections involving the conjunctiva and cornea. Topdex is effective in ocular inflammation associated with superficial bacterial ocular infections. The Topdex, this is the FDA-approved therapeutic indications, the combination of an antibiotic and a steroid for the treatment of steroid-responsive inflammatory ocular conditions for use for which a corticosteroid is indicated and where bacterial infection or a risk of bacterial ocular infection exists. From data, it's seen that this combination, it has a mainstay and widely used within in the ophthalmic role. It's used, these preparations are widely used in the prophylaxis of infection and inflammation after eye surgery. And basically, just to cover what Topdex covers, it provides action against a suitable organism of the following microorganisms. I won't get into the details, but just to highlight the staph group, Staphylococcus group, Streptococci, and the Pseudomonas and others that are mentioned across the slides. And the common manifestations of these inflammatory conditions due to these bugs include the bacterial blepharitis, bacterial keratitis, bacterial conjunctivitis, and blepharokeratoconjunctivitis as well. This is data, one of the studies I came across that was proving the efficacy of Topdex combination for post-op usage. And this was a study that compared the combination of tobramycin and dexamethasone with the dexamethasone, neomycin, polymyxin B. That's a common combination that is used in this setup, and neomycin, polymyxin, and gramicidin for control of inflammation after cataract surgery. This was a multi-center study, prospective, 3-arm, randomized, double-masked, controlled parallel study group done in 2004. The objective was to demonstrate the non-inferiority of Topradex and dexamethasone compared with dexamethasone, neomycin, and polymyxin B combination in terms of anti-inflammatory efficacy, and to compare the anti-inflammatory efficacy of tobramycin and dexamethasone and the DNP combination with that of a placebo control. This is the one that did not have an anti-inflammatory agent, and to further provide additional safety data on tobramycin and dexamethasone. The conclusion of the study, in the interest of time, I just summarized it. In this study, of patients undergoing cataract extraction by either manual extraction or pharmacoemulsification with IOL implantation, ophthalmic tobramycin dexamethasone combination was shown to be non-inferior to ophthalmic neomycin polymyxin B dexamethasone combination, concerning inflammation scores at days 3, 8, 14, and 21, meaning that top days can usually be used in this setup, just as the way the DNP combination is widely used. Tobramycin and dexamethasone was also shown to be well tolerated, meaning that its safety was also shown in the study. To finalize, I told you about the dosing and administration of Topdex. We instill 1 to 2 drops every 4 to 6 hours daily as directed by the physician, and the patient response might vary and may increase it to every 2 hours during the initial 24 to 48 hours. Frequency could also be reduced gradually as improvement is seen. For a period of 7 to 10 days, we know the concern with the extended use of corticosteroids, so it needs to be limited in terms of the period that it will be used. And then this captures some of the contraindications on warning: hypersensitivity to the product, herpes simplex keratitis, mycobacterial ocular infections, and fungal diseases. Key warning: prolonged use should be avoided to reduce the risk of elevation of intraocular pressure. In special populations, I thought that maybe this session, having discussed about pediatric, just to cover something mentioned about Topdex in the pediatric population. The safety and effective in children below 2 years has not been established, but above that can safely be used. In pregnancy, corticosteroids are associated with fetal growth, and this should, combination with Topdex should only be used if the potential benefits clearly outweighs the risk to the fetus. For geriatric use, where most of these cataract surgeries and other surgeries occurs, we say that it's shown that Topdex has no difference in effectiveness between the younger and elderly patients. In conclusion, Topdex is an effective and safe combination in the management of ocular inflammations responsive to corticosteroids that are associated with the risk of presence of superficial bacterial ocular infections. This I conclude my presentations, and thank you very much for the opportunity and for the support that the organization and the prescribers have been collaborating with the organization and making our products available to the patients. So we say that Topdex is available for you to use in this space as we resolve the issue with the Oracle DM. We believe in offering you an alternative not to leave a vacuum in this area. And also, just to, as I've highlighted, we have an entire range of products for all your ophthalmic needs. Thank you. And unless there's a question, I want to return the session back to Dr. Kalu.
Thank you, Evans. Thank you very much. Thank you all of us for attending and for giving us your time for this evening. It was a very wonderful presentation. I hope we will put into practice and do more cycloplegic refractions. And thank you, Evans, for this medication, some of which we've been using, though we have not met the face of Dawa Pharmaceuticals. So we will continue in collaboration. I want to remind us the next CME will be in May 13th. The topic will be communicated in due course. And thank you all of us for coming this evening. And I hope you have a very good evening. And that brings us to the end of today's CME session. Thank you. You are free to leave at your own pleasure.